Moved on to the Sylvester Comprehensive Cancer Center at the University of Miami. So Dr. Frank Penedo, he's an internationally recognized expert in cancer survivorship and psychosocial oncology. He's now Associate Director for Cancer Survivorship and Translational Behavioral Research at the Sylvester Comprehensive Cancer Center at the University of Miami Health System, and he also co-leads the Cancer Control Research Program there. He's a professor in the Department of Psychology in the College of Arts and Sciences and holds a joint appointment in the Department of Medicine, Division of Population Health and Computational Medicine at the Miller School of Medicine. Dr. Penedo's work evaluates the role of sociocultural, biobehavioral, and psychosocial mechanisms underlying disease activity and health outcomes, and the efficacy of evidence-based psychosocial interventions in promoting optimal chronic disease management and health outcomes in cancer. His work also involves translational research evaluating the impact of symptom and toxicities monitoring and management in ambulatory oncology, the patient-reported outcomes in survivorship care, precision oncology, and phase 1 trials, as well as the implementation of evidence-based behavioral interventions delivered within health systems and the community to improve patient and system-level outcomes. Welcome, Frank.
Thank you, Chris. It's really an honor and a privilege to be back in what I still consider to be my academic home. I still feel like I work here. I'm on the phone every week with one of the speakers, more than once a week, actually. I was given the task of talking about the future of cancer survivorship. I think you've heard already a lot about what's really are these emerging topics that are really critical to the care of cancer survivors. And the benefit of following the amazing talks that we've had is that it makes my job easier. The bad part is I stand between you and lunch, so I will do my best to get this moving quickly. I have no disclosures to report. I think when we talk about the future of survivorship, we need to talk about the history and how we got to where we are at now. Dave mentioned the impact of Fitzsimmons and when he was talking about the different seasons of survivorship, and across the past several 25 years, we have had critical advances in the field. And I would argue that the NCI establishing the Office of Cancer Survivorship, the Institute of Medicine or National Academy of Sciences report of loss and transition, and the COC standards have really been pivotal points to push the concept of cancer survivorship and have brought us to where we're at now. You have seen this figure before. We've been staring at this for almost 15 years now. We know that the number of cancer survivors will continue to increase. Currently, we have about 16 million. As a result of early detection and treatment efficacy, we've seen really an unprecedented growth in the number of survivors, and they account right now for 5% of the US population. The 5-year survival or relative survival rate is about 68 to 70%. It used to be about 50% back in the 70s. And we are facing a challenge, which I'm going to talk a little bit about today, that 64% of our survivors are 65 or older, and by 2040, 73% of our survivors would be over the age of 65. Some have coined the name. Dave mentioned the Great Wall of China falling, and maybe that breakthrough of the field of survivorship back in the 80s. But we're really going to be facing what has been coined as the silver tsunami by Catherine Alfano at the ACS, who directs the Division of Survivorship. And what we're seeing is if we look at the percent of the US population that's alive today and living with a prior diagnosis of cancer, it's about 29% of women and of men and 20% of women between the ages of 75 and 84, and about 40% of men and 25% of women for what we call the old, the 85 and older. And what this brings is the challenge that within normal age-related changes that patients face, the patients are already experiencing functional declines, financial challenges, multiple comorbidities that add complexity to their care, and care coordination problems, which, as we know, is a central challenge that we still to face in cancer. So we can't really overlook the fact that the cancer survivorship population is aging, and this is going to be one of the major challenges we're going to be facing in the next several decades. Going back to some of the pivotal points in the development of the field of survivorship, as I mentioned, the Office of Cancer Survivorship, which was founded in the National Cancer Institute in '96, really has been a driving force in major efforts that have led us to understand and comprehensively address the challenges of survivorship. And as you can see from this wheel, which many of you have probably seen before, it's a very comprehensive approach. It's not only about symptoms or specific populations, but also looking at things like financial toxicity, caregiving, and other factors that are affected or impacted by cancer. Collectively, the research that has been funded by the NCI, the ACS, and other organizations have allowed us to characterize the burden of cancer survivorship across the care continuum. And this is not an all-inclusive list, but we know that diagnosis comes with uncertainty, anxiety, and depression. We also know that the NCI and other organizations define a cancer survivor as somebody from the day of diagnosis. Then we have treatment planning, which brings up the challenge of decision-making, communication with the provider, understanding, knowledge, and literacy issues, followed by when actually treatment begins, whether it's neoadjuvant or primary treatment. The patients face symptom burden, interpersonal disruptions, treatment response concerns, and of course the cost. And eventually, for the longer-term survivorship, we're thinking about late effects of therapy, ongoing surveillance, fear of recurrence, and other issues. And these can be exacerbated by multiple factors. There's an enormous amount of research suggesting that older individuals that have poor premorbid function, so history of depression, anxiety, or other chronic conditions, more comorbidities, have more exacerbated symptom burden and poorer adjustment to a diagnosis of cancer. Somebody already mentioned the Institute of Medicine as being one of the, also putting out a very influential report that really highlighted the fact that as a field, we were not doing a great job at paying attention to the concerns or the needs of survivors and needs from a comprehensive perspective, the physical, the emotional, the social, financial, etc. And they also suggested that more work needed to be addressing how do you effectively deliver care to these survivors across the cancer survivorship continuum. So we're talking about tsunamis, now we're also talking about a perfect storm, as that has been coined also by Alfano and Deb Meyer, who's the active chief of population of survivorship in the NCI. And other concerns or other challenges that we're facing is a shortage of oncologists and trained PCPs, as was mentioned earlier by Dr. Kircher. These ever-changing and evolving accreditation standards, provider knowledge deficits that we face, and a set of disparities in outcomes, which you heard about and you will hear some more about today. So what I wanted to talk about were 4 key areas of current and future research in survivorship. One of them being PRO's assessment, which you've heard about all morning. This is actually, it's an area that has emerged as a really important and critical area of study and interest for the National Cancer Institute, for accreditation bodies, understanding the importance of capturing patient experiences and being able to improve cancer care delivery, and of course, using technology to optimize the assessment of PROs. I'm going to talk a little bit about comorbidities. As cancer survivors are living longer and are getting older, they're facing a series of comorbidities that can be exacerbated by the cancer experience. I'm going to talk a little bit about precision psychosocial care, and you heard from Bettina, how do we address specific concerns of populations, not only from a symptom burden perspective that gets aligned to specific therapies, but also for racial and ethnic minorities. And I'm going to move fast. I was given the task to try to move through this to give enough time for questions. I'm going to talk a bit about health literacy and communication, which is a very important area. The National Academy of Sciences recently convened a work group to promote, enhance, develop communication efforts in oncology care, including survivorship. And I'm not going to talk about these in specific, but again, I want to also emphasize the fact that there's a lot of interest in addressing rare or less common cancers that have been typically not studied because of feasibility reasons, because they're not common and they're rare. Long-term outcomes in adolescents and young adults, which you'll be hearing about later today. So let me start with PRO assessments. You've heard about the importance of measuring patient experiences. This aligns with the concept or the notion of value-based care, which many health systems are really focusing on. And the idea here is that the focus is to improve the quality and precision of care while at the same time minimizing cost. And this is not an easy task, and it really involves shifting the attention from volume of patients to value of care and quality of care. The teams are now tasked with thinking about the entire patient experience within and outside the clinic, and particularly between clinic visits. And the provider mindset has to shift in terms of patient engagement. Again, how do we keep patients engaged within the system in an effective manner that's going to optimize their care? We also, one of the pillars of this is also the use of technology, capturing information about the patient experiences outside of the clinic setting, and using this information to improve workflows, create efficiencies within the healthcare system, and effectively implement best practices. We know from the literature that patients want to be engaged, they want to be active participants in their care. This is a study with 1,068 patients. Collectively, if you look at the rates or the percent of patients who strongly agreed with these comments, most of them, obviously, they said that they wanted to feel that the doctor had listened to them, but they also wanted to also be informed fully about their diagnosis and their probable prognosis, and also about the risk associated with treatment options that were available to them, and how these treatments were going to impact quality of life. And this is one of many studies that have suggested that patients want to be active participants. They just don't want to show up to the clinic and be told what they should be doing and how. So one way that we increase this patient engagement is by capturing these PROs we've been hearing about all morning. So PROs are important because it helps us evaluate the symptoms and functional capacity, quality of life, and other patient experiences that are taking place. And another factor that's driving the use of PROs is that we know that clinician ratings of symptom severity are often lower than those reported by the patients, especially for areas or subjective symptoms like fatigue, depression, and anxiety. So some of the benefits of capturing these patient experiences you've been hearing about: you can promote individualized patient care, more precise care for the patient if you know what their symptom presentation is. You can enhance patient-physician communication, and from a patient engagement perspective, you can facilitate shared decision-making and help patients measure progress over time. This is some data showing the proportion of underreported toxicities. The blue bars are any toxicity, the red bars are severe toxicities that are missed by clinicians. This is a mixed sample of breast and lung cancer patients. And if we look at any toxicity, 74% of anorexia, 41% of nausea, and so on were missed by clinicians. Yet if you ask the patient through a PRO measure, they're reporting that these are concerns to them. I'm not responsible for the icons, they're really not in good taste, but I did want to summarize the rates. This is what happens when physicians try to describe data. So in any case, as was mentioned earlier, the NCI recognizes the importance of capturing these patient experiences, and they have put a lot of resources into funding the IMPACT program, as was described earlier, which is really allowing the implementation of the systematic patient-reported outcome measurement through 3 major health systems, including Northwestern Medicine, Mayo Clinic, and Dana-Farber. Of course, now that I'm back in Miami, and warm weather is overrated, I have to tell you that. It's extremely hot and humid. But my colleagues didn't feel bad for me when I said that I got dirty looks. So of course, we with the expertise here and with Dave's guidance and Sophia and Sheetal and others and the work that we all did here, I'm implementing a very similar system in Miami, which is modeled after what was built here at Northwestern, which we call UHealth Pro. This is just a summary of what we do with that system. It's based on the patient portal and fully integrated in the electronic health record. And I'll give you a schematic that probably simplifies that slide. So we look at patient eligibility using ICD-10 codes. We start administering these measures at the second visit or later, because we know that the first visit tends to be a bit biased with anxiety, distress. We don't assess this more than once a month, and we're always assessing this when the patient's coming in for an appointment. We send a text and an email 72 hours prior to the appointment telling the patient that they have several measures to complete through the patient portal. So what we assess, we have two levels of assessment. We ideally want to get the patients to complete this through the patient portal, as you saw earlier in some of the presentations, and we have a second level of assessment, which is at the clinic, and that's for patients that didn't use the patient portal. We used very similar assessments here, the PROMIS CATS, nutritional needs, practical needs. We're looking at some specific symptoms or toxicities, and we're also looking at a very brief measure of quality of life, more as a research measure. And like I said, this is in real time in the electronic health record. If the patient doesn't generate an alert, meaning that they don't have a nutritional need, a practical need, they don't have elevated scores in any of the domains, we reassess them every 30 days when they're coming in to an appointment. So if a patient's not coming in for 3 months, they don't get reassessed for 3 months. If the patient has an alert, then we triage them to social work, nutrition, or the medical team, and then we have a disposition recorded in the electronic health record to track what the alert generated and how it was managed by the teams. So a lot of work goes into building the systems, the IMPACT program, the Lurie Screening Initiative that Dr. Garcia described, follow these implementation models or frameworks, which are very comprehensive, very detailed and involved. And we followed what has been described as EPIS implementation framework, which involves exploration, preparation, implementation, and sustainment, looking at the outer context, meaning policy, funding opportunities, needs, looking at the inner context, like the health system, the capabilities, the resources available, and then what they refer to, or what the model refers to as interconnectors, which are bridging factors and innovation factors like technology. So just to simplify what this very detailed model involves, it's really 4 phases that are, it's a logical sequence of the steps you take to implement these programs. You have phase 1, which is an exploration phase, and that's where you want to have program alignment with priorities, needs, and system capacity. So we know that PROs are an area of interest, it's an area that's fundable, it's an area that can optimize care and aligns with value-based care. The second phase is the actual the adoption and preparation, paying attention to what are the barriers and facilitators of implementing the program. The third phase is the active implementation, where you initiate the program and evaluate it. And then you have phase 4, which is sustainability, which is you continue with the program and you start looking at what is the measurable impact in public health. So again, a very detailed sequence approach to implement these programs. So if we look as an example for that inner context, these are the steps that take place when you're developing a program like the Lurie Screening Initiative, the NM Pro, UHealth Pro, these types of screening programs. And the first step, you have to have stakeholder engagement. And that involves individuals from multiple areas, from the EHR, from patient experience, which is really the patient-facing interaction between the health system and the patient, supportive oncology, and other services. The second step involves clinical operations and workflow development, identifying the clinics where you want to start with. We actually started in the Gyn-Onc clinic, as was described to us as probably the best place to start, and that would give us possibly a somewhat biased reflection of how the system would eventually work, but we wanted to start with low-hanging fruit in some way, and we had quite a great buy-in from the providers there. And then you move on to evaluate the clinical and EHR workflows, the program dissemination, how are you going to promote this through the clinic and with the patients, and then you have your pilot test and your feasibility and usability within other clinics. This is just to give you an idea. So for example, we had focus groups with patients, just showing them the program, asking them what they like, what they didn't like. The text in white highlights probably the major themes that we got. Overall, the patients said that they liked this program, that they wanted to be engaged, but they wanted to make sure that the data was being used for their care. They just didn't want to fill out a measure for the sake of filling it out. And they wanted to be able to get some feedback in real time on how they were doing. They also felt that it was useful if the feedback was given to them right away, as I just mentioned. And they raised the fact that they wanted to add a family and caregiving component. And then somebody raised that question earlier. They felt that the caregivers, their spouses, partners, were really critical individuals in their care and that we were not asking about them. Although there is a question in the practical needs about family and caregiving, but not in the PRO measures that we were giving. We also put in a lot of energy into training the Gynonc staff. So we developed a very comprehensive training guide, which is still in draft. As of today, I can tell you we've had over 62 IT revisions, meaning IT has to go in and make changes to something for some reason. So we still have a draft. But in any case, we show the clinical workflows of how this works so that the clinicians, the patient navigators, the intake nurses are aware of the process. And we inform them and educate them about PROMIS, the value of this measurement system, the value of this computerized adaptive tests, which are short, brief, very feasible way of assessing these symptoms. And then the disposition. So in the EHR, they're able to put a disposition for how they manage the alerts that they're receiving. We also have patient-facing materials. Probably this is an area where we could have done a better job, and we're trying to improve this. We develop a brochure describing the program. It's very text-heavy, probably not very something you would just want to pick up and read. So we're working on some different materials now, but at least it has comprehensive information about the program. And this is what our patient interface looks like on a web. It looks very similar on a phone. So what is the data telling us up to now? So we have assigned 277 patients for the UHealth Pro between August 14th and October 25th. These are only English-speaking patients. Out of the 277, 51% did not open or start the assessment, and this is not that different from what we see in other health systems. 49% opened it, 7% did not complete it. So we had a 42% completion rate. So it's not great penetration in terms of uptake by the patient, but it's not that different from what we're seeing. And keep in mind, we didn't inform or educate the patients before we launched this, and that's something that we're doing different for the next clinic, which we're going to launch, which is a lymphoma clinic. Where are the patients completing this? Well, this is a problem too. Most of them are doing it in the clinic. That's resource intensive. It's doable and it works, but when you have almost 70% of your patients not using the patient portal to complete this, that's problematic. So we at the clinic use various touch points. We have iPads, we have kiosk, and we have the intake nurse who can do a hyperlink within their display for the patient to complete it. In terms of alerts, same number of alerts. So this is about, for the patients that do open and complete it, about 15% had an alert for depression, and the same number had an alert for anxiety. 27% of the patients had a practical need alert. 36% had a nutritional need alert. And what do these needs look like? Well, for practical and psychosocial needs, financial needs, transportation, and general education and information and advanced directives were the top 4 alerts that were generated for social work. If we look at nutritional needs, general nutritional counseling related to oncology, difficulty losing weight, and information about vitamins, supplements, and herbs were the top 3 needs. And I don't know if that's very similar to what we have here, but the issue of herbs and supplements is it's a complex issue for many cancer patients. And this is just a screen of how we track dispositions. We also have dot phrases where the social workers or the nurses can enter what work took place with the patient, but typically we code whether the specific alert was addressed by the provider, whether the patient was referred internally within the UHealth system or externally outside of the system. Now, here's where we're not happy about where we're at with this. So this is completion alert by providers. And remember, this is just one clinic, English speaking. This is not the entire clinic. But if we look at response to alerts within 72 hours, which is what we tell the providers they have to do, 40% of physical symptoms, and there's not that many, it was only 16, but nonetheless, 40% of them were not addressed within those 72 hours. Social work does better with emotional distress and practical needs. Nutritional needs is a problem. It was a problem when I was here with nutrition services. Health systems don't have enough nutritionists to manage this. And pro-CTCA, we had a lot of alerts, and I've talked to some colleagues here about that. There might be some issues with some of the items, but nonetheless, the pro-CTCA, because they're reporting severe toxicities, the providers were more keen about addressing those. But we will not roll out this to the next clinic until we're at 90% of responses. And it's a high bar, but it's where we want to get at. So this shows some of the challenges, I think, and the complexities of rolling out these programs and getting the provider buy-in. And it's something that we continue to work on today. So I wanted to shift gears and talk a little bit about cardiometabolic risk in cancer survivors. Again, patients and survivors are living longer. Cancer doesn't exist in a vacuum, it exists with other comorbidities, and cardiometabolic health is becoming more central to these survivors. I know Dr. Phillips talked a little bit about this, but if we take a deeper dive into this, we see that survivors are more likely to have a higher burden of chronic disease, particularly diseases like, or risk factors and diseases like type 2 diabetes and cardiovascular disease relative to the non-cancer population. There's a variety of reasons for that, some of it related to treatment-related toxicities, as many of you know. And we find that pediatric lung, non-Hodgkin's lymphoma, and multiple myeloma cancer populations are at greater risk of these cardiometabolic or treatment-related cardiac toxicities. So if we think about cancer treatment toxicities and lifestyle factors and aging and the interaction of that, the question is, what is the cardiometabolic risk that this can render in cancer survivors? And this is problematic because lifestyle factors, physical inactivity, poor nutrition, can lead to central adiposity, which is part or a contributor also to the metabolic syndrome, which we know is related to incident type 2 diabetes, and collectively these are all related to cardiovascular disease. So many programs have now, or some programs in survivorship have become very specific and developed programs to actually address the risk or the cardiometabolic health of cancer survivors. The American Heart Association has put very specific guidelines on how to manage patients that have received treatments that are related with cardiac toxicities, for example. They have put out clinical pathways, for example, for patients receiving high-dose anthracycline, and whether that's related to any cardiac symptoms and how that leads into a cardiovascular disease consult and eventually a cardio-oncology rehabilitation program. And these programs are actually quite comprehensive, or at least in concept, how they've been developed and described, they're quite comprehensive in dealing from everything from health behaviors to psychosocial needs of these patients. So I think as we think more of where the field is going and what we're going to be seeing more of that we haven't seen much of until now, although cardio-oncology continues to be an emerging field, is this type of rehab programs that can be embedded within survivorship programs. I'd like to highlight some of the work done here with collaborations with Tammy Stump and Bettina Yanes, where they have actually interviewed and conducted qualitative work looking at perceptions of oncologists about these lifestyle factors and their impact on cardiometabolic health. And what they found, this is interviewing 90 physicians, about a third were oncologists, a third were specialists like urologists or gyn-onc physicians, and the other third were primary care physicians. Collectively, about 72% of oncologists and 90% of specialists do not recommend lifestyle changes, whether the patient is obese, or they have diabetes, or they have other risk factors. And if they have limited time, they said they almost had no discussion. I think I can understand that to some extent. You're dealing with a cancer patient. Many of their presentations can be complex, and to talk about nutrition and physical activity on top of that is probably not the priority. So that's understandable. And fortunately, about 50% are willing to refer patients to what has been coined as a lifestyle specialist or health promotionist, which I think Tammy, who might be here, is credited with coming up with that term, or maybe Money Spring. But in any case, if we look at what some of the barriers of oncologists have in implementing these lifestyle discussions, they feel that the patient may have low performance status, or the patient has difficulty with pain control, so exercise wouldn't benefit them, but I don't think that's intuitive. It's actually counterintuitive. And then that the patient's too stressed. Again, exercise is a stress reliever, but they won't talk about it because the patient's too stressed. So it's mostly a lack of education and focus on the benefits of these lifestyle factors. So going back to this health promotionist idea, and this is a study that, or review paper that was put here led by Bonnie Spring, along with Tammy, myself, and other colleagues. It's the idea of having this health promotionist that, in addition to having these survivorship programs and clinics capturing patient-reported outcomes specific to symptoms and toxicities and other psychosocial factors, is having a promotionist that's also capturing information on, or vital signs, if you will, on obesity, on physical activity, on smoking, on alcohol and other drug intake, and using what we have now, the abilities we have now in the patient portal and the electronic medical record to communicate with providers about where the patient is at and these risk factors. And of course, having this health promotionist be able to implement psychoeducational or informative interventions to help the patients manage these lifestyle challenges that they may be facing. There's also the idea of the digital patient health record, which tracks somehow like what you saw from Dr. Phillips with their physical activity, their weight, BMI, and things like that to help the patient become more engaged in the care of their overall health outside of cancer. So I'm not going to spend much time talking about communication, just to leave some time for questioning, but one area that's also emerging is the issue of effective communication. There's a lot of confusion. We have this with the benefits of advances in therapies that are highly effective, the advances that we're seeing in genomics. At the same time, that's creating a lot of confusion for patients. I remember when we started working here in the clinic with looking at molecular profiling of tumors, and when the phase 1 clinics, some qualitative work done by Dr. Yanis was identifying that oncologists were even more stressed in some cases than patients, because patients were coming in with false notion or misunderstanding about what these programs did. So they heard, oh, I know that you can do precision medicine, you can look at the genomic profile of my tumor, and I can get treated for that. And we know that reality is different. Less than 10% of patients qualify or have an actionable mutation. The trial has to be open, the drug has to be available. So it's very complex. So the National Academy of Sciences actually recently convened a panel on how do we improve communication in patients. And I'm going to skip through some of these just in the interest of time. But I did want to highlight this study. This actually looked at whether the quality of patient-provider communication about survivorship care, whether it had improved from 2011 to 2016. Keep in mind, the COC standards went in 2012. That's when we started chasing our tails to implement survivorship care plans and meet the requirements. And if you look at the red line, that's 50%, and anything above that is a percent of cancer survivors that did not get detailed information about the specific category that's listed below. So like later long-term effects, no change. Lifestyle recommendations, no change. Emotional and social needs, no change. So again, care plans, we think that it's a great idea in many ways. We can summarize their treatment, we can specify follow-up care, we can communicate with primary care providers, but from a patient's perspective, this really didn't move the dial in these discussions. I think not only myself, many have argued that one way to improve communication about survivorship care is also starting at the point of diagnosis, rather than waiting till when survivorship care actually begins, which is post-primary treatment. So that's maybe one way that we can address some of the problem, or partly, is beginning these discussions about survivorship care at diagnosis to begin the patient engagement process to help the patient understand what to expect throughout the care continuum. So let me move to the next. So I wanted to spend a couple of minutes talking about adapting evidence-based interventions for specific populations. Again, when we're thinking of precision medicine and precision care, it's not only about medications, it's not only about treatments, it's also about psychosocial treatments that we have for patients. And for many decades, many individuals in my field have been conducting manualized interventions to help improve quality of life and reduce symptom burden in cancer patients. And these interventions have been adapted to multiple cancer types across genders and to some extent to specific racial and ethnic minorities. And you heard some of this from Dr. Yanis earlier on, but I want to focus a little bit on cancer in Hispanics and particularly prostate cancer in Hispanics in the United States. So there's about 58 million Hispanics in the US, or 18% of the population. Cancer is the leading death among Hispanics. It's not the leading death for the general population, but it is for Hispanics. It accounts for 21% of deaths. Hispanics are less likely to be diagnosed with many of the common cancers. So we tend not to think of them as a high-risk group, so lower rates of lung, colorectal, breast, and prostate cancer, but they show poorer outcomes. And in some well-controlled studies, even if you control for access to care, socioeconomic status, education, etc., you still find that you have poorer outcomes, and even in quality of life among Hispanics. They also tend to have a higher risk for cancers associated with infectious agents, and they have also less access to care and high rates of uninsurance. So aside from Native Americans, they have the highest rates of non-insured or no insurance from racial ethnic minorities and the lowest levels of education. So collectively, these factors, of course, create a contextual risk for these patients in order of being able to access care at the right time and effectively navigate through the health system to get optimal care. So collectively, we look at Hispanics relative to non-Hispanic whites, lower incidence and mortality, but present also with more advanced disease. This is particularly the case in prostate cancer and in breast cancer. They're less likely to achieve baseline functioning, again, controlling for factors that may drive that overall functioning. Poorer general and disease-specific health-related quality of life, and less psychosocial resources. The interventions that have been developed and have been effectively delivered with favorable effects have not really been well adapted for these racial and ethnic minorities from a cultural perspective. This is the general intervention model for a very commonly used paradigm, which is cognitive behavioral therapy. It views cancer treatment and treatment-related side effects as a major stressor, which presents various psychosocial treatment targets like coping skills, relaxation techniques, communication skills that can be addressed through groups or group therapy. These are expected to improve emotional and behavioral adaptation and physiological adaptation, and eventually impact quality of life and health outcomes. And the question is, does race and ethnicity modify how we deliver these interventions or the targets of these interventions? So I'm going to talk about a study where we actually have manualized, we've disseminated it to community audiences, and it's considered to be an evidence-based treatment in the sense that it's CBT impacting quality of life and other outcomes in cancer populations, and we have documented extensively the effects of these programs on quality of life, stress management skills, coping, mood and benefit finding. And we have also documented that we can get clinically significant effects of these programs, but only for, in this case for prostate cancer, for men who are coming in with high levels of anxiety, social inhibition, or high levels of stress. So in other words, for the men that really need it and are some sort of deficit. So we were very interested, my group here and then in Miami, and in continued collaboration here with Northwestern, in understanding how these conceptual or theoretical cultural factors that we're aware of in Hispanic communities may impact response, if you will, or movement through these psychosocial interventions that have been very effective in general populations. And these cultural factors, many of them are theoretical, not a lot of empirical backing behind them, particularly when it comes to interventions. But many have written about this. Marine started this out in California, and others have replicated some of these work and applied these theories. And they have agreed that there are these set of core values which are pretty common across collectivistic cultures. So I'm talking about Hispanics, but African Americans share some of, or many of these values, and other collectivistic cultures like Asians. So the concept of familism, a strong family interdependence or attachment, which is a good thing to have, but it has a psychosocial implication in the context of these interventions. Hispanics tend to not be as willing to engage in support groups, for example, or these programs if they don't have a perceived benefit to the family as well. So it's not only about the self, but also about the family. The other concept would be fatalism, an external locus of control, which suggests that destiny is beyond the control of the individual. If you have this fatalistic attitude, you're probably going to do very little to change your behavior or to engage in healthcare because you think or you believe that there's not much you can do to change your outcome. So we work with the patient to build self-efficacy and teach them how culture can shape these fatalistic beliefs, and being aware of that can help them reconstruct those negative patterns of thinking that may interfere, create barriers for them to effectively engage. I say all and then of course we have gender roles and agreeableness or sympathia and other factors that we don't have time to get into. I do always say this with the caveat that we don't stereotype. We always present this as these are patterns that tend to be common in Hispanics, but that doesn't mean that every Hispanic has these patterns. So we followed 4 stages of cultural adaptation of these evidence-based programs that we have been working on for several decades. And this is a model by Bernal, who has done a lot of work in cultural adaptation, which involves information gathering. What does the literature tell us? What does theory tell us about these different racial ethnic groups? We do a preliminary adaptation of the intervention. We test that adapted intervention with trained facilitators, and then we do further refinement. So it's like an iterative process where we keep changing until we get enough feedback suggesting that the intervention is culturally informed and culturally adapted. So we did some initial work on this, finding that participants, Hispanic participants, and keep in mind when you're doing this in Spanish, you're dealing with the confound of acculturation. So Spanish monolingual participants relative to bilinguals tend to be obviously less acculturated, with language as a proxy of that, but also they tend to have spent less time in the US, perhaps have lower levels of education. So information provision was a big component, just even explaining what prostate cancer was and what it wasn't. Greater emphasis on fatalistic attitudes and external locus of control. The role plays or any homework exercises had to be more specific to family roles, more attention to assertiveness training and communication skills, and more therapist awareness of social cultural processes. And with that, we ran a pilot a while back, and we found that we were getting main effects of this pilot on sexual function and quality of life. And these are just 2 examples. Whereas with the other intervention, it was only benefiting men who were coming into the intervention with higher levels of distress. So this suggested that this group, and in fact we compared means, and they were more compromised than the larger population that included bilingual Hispanics. So we took that and we developed a culturally adapted version of CBSM, and we proposed a trial to look at the incremental efficacy of the culturally adapted intervention on health-related quality of life and symptom burden. And the idea is that men undergoing the trial or the intervention that is culturally adapted would derive greater benefit from participating in the intervention relative to men who were undergoing the standard intervention, which was just a standard linguistic translation with no attention to culture at all. And within this context, we're looking at several mediators, which are the cognitive behavioral therapy techniques, relaxation techniques, and neuroimmune regulation and gene expression, because we're also very interested in underlying biobehavioral pathways that explain how these mechanisms impact symptom burden. We did cultural tailoring of the interventions. Some of this was derived by focus groups, some of it was derived by the team. So for example, we created more didactics on cultural patterns. So we have like a cultural focus, how culture can impact the way you think, the way you behave, the way you interpret information. We played more emphasis on reducing cultural stigmas about cancer and emotions, how adages influence appraisal and coping processes. Hispanics told us that they wanted to hear these sayings or adages and how they applied to their disease. How culture may influence sexuality. Of course, we talk about machismo and gender roles and intimacy, and a peer story as a frame of references. And I credit that, to Dr. Yanis, who said that with some of her work, she had noticed that patients wanted to have a peer or a reference point that they could relate to. And we created the story of Pedro or Juan, if there was a Pedro in the group, that basically went through all the sessions of the intervention with the participant, and we shared the experiences of this avatar, print avatar, if you will. So, and that trial is running now. We've recruited about 70 of 260, and we just recently got a supplement, or about a year ago, we got a supplement to it to look at some physiological markers in the field that will augment the generalizability of the skills that are learned in the intervention to what the patients actually do in their environment. So if I had a crystal ball, what's next with survivorship? I think looking into the future, keeping in mind survivorship and the field is about 15 to 20 years that it's received major attention from some of the points that I discussed earlier. If we see where this is going, comprehensive management that is patient, family, and caregiver engaged. Again, this was raised by somebody in the audience. I cannot emphasize enough the role of family and caregivers. I just didn't have time to go into that. But caregivers, not only are they stressed themselves of working with patients, but their stress also impacts the patient. So there's a dyad there that's of critical importance. Of course, what we are aiming for is having quality care nested in everyday care, and the issue of primary care settings has come up as well. How do we move some of these concepts to primary care, knowing that oncologists are not going to be able to maintain or keep up with the numbers of patients? Some suggest that care might get worse before it gets better, again, because of the silver tsunami being one of the factors, this growing number as baby boomers are moving into their 70s and 80s. And the major challenge we have is to get high quality, comprehensive patient-centered care implemented in everyday care. And something we didn't talk much about today, but at some point we have to address is big data. How do we deal with the enormous amount of data that we're collecting through many of these programs? This is just a quick slide on technology. This is from Peter Tippert, who used to be the chief medical officer of Verizon. I think this is from 2015. He was arguing that similar to the internet revolution, mHealth is revolutionizing the way patients receive their care. There's a lot of applications that are available now. From a financial perspective, the global market for mHealth is about 49 million, or was 49 million. It's expected to be 49 million by 2020. And 95 million Americans in 2013 were using some sort of health application. There are currently over 22,000 apps available that are health specific, and the majority of them are not evidence-based. They're just good ideas that look great, but they haven't been tested. So that's why I think the work that Shaban and Bettina are doing with these apps and trying to develop an evidence base for their use is going to be critical and eventually impact this. So I think just some general conclusions. A relatively new field, the growing numbers, aging population, greater disease morbidity, poor lifestyle behaviors, and the ongoing expensive and fragmented care that we have is really going to require large-scale and paradigm-shifting solutions. And we're seeing some of that through the IMPACT program, and that's funded by the NCI. Patient engagement and delivery of precise care is critical. We need to balance implementation and dissemination studies with further discoveries via RCTs, particularly in the areas of ethnic minorities and disparities work. I think we're ready to disseminate and implement a lot, but there's also a lot that we still have to discover through very controlled studies. And getting back to that is the ecological validity and generalizability across populations. Is this going to really help everyone? How does this impact patients that are not in very wealthy, very well-resourced health systems? That's a big question. So with that, I'll end. I want to acknowledge my long list of Northwestern colleagues and collaborators and friends, and the funding sources for this work, and thank you. Yes.
It's kind of a loaded question, but a lot of the stuff that I think that we talked about today, patient-reported outcomes, the apps, all of survivorship care plans, survivorship care planning in general, all so far falls under the unbillable and reimbursable services. What's for the most part? What do you think from a research standpoint, outcome-wise, we should be building into these studies to help make the case, the argument for some level of reimbursement in that kind of health systems care about, or payers?
Thanks. It is a loaded question. I wouldn't expect otherwise. For me, it's a little bit out of my comfort zone, and we need to think more about that. What is the cost-benefit ratio of this, and how do we maximize how we fund this, and can we bill for this? What comes to mind, telehealth visits, for example, are billable, so we can bill for some of these services. There's some talk about making apps FDA devices, which then you can bill for. But I'm curious to hear if anybody in the audience, or even if Rebecca, who's the administrator, has thoughts about that, because that is a major challenge that we have. We could come up with all these wonderful bells and whistles and have the evidence base for it, but if it's not sustainable from a financial perspective, it's not going to fly. It's the sad reality. So.
Another question.
Mm-hmm. Yeah.
So when going back to kind of an in the weeds question of, in your PROs that you've done at Miami, you had mentioned something that we don't do here, which is when a physician gets an alert, can you explain a little bit more of what happens as far as what happens with that alert? Because that's kind of the...
Yeah, so they have a BPA, a best practice alert. They don't get a hard stop. So they can ignore it, but it'll keep popping up for 72 hours after it's generated.
After that alert is generated?
After the alert is generated. No, after the patient visit. It's got to be addressed by 72 hours after the patient visit. So that's
where I got...
That's a timestamp, which I think it's different from how you were doing. It might be different from how you're doing.
Ours is 72 hours before the visit, the patient gets the survey.
Right.
But I guess I misunderstood that you weren't thinking that the physician was going to do something in that 72 hours before the visit.
So they get the patient gets the message 72 hours prior to the visit,
Okay.
and then the provider has 72 hours from the visit on to
Got it.
address it. Yeah, and that's where we're still running. You saw the percentages of completion, where we're not at 90%, which is where we're shooting for.
And they get that alert starting 72 hours after?
They get it in real time.
You get it in real time.
So technically, they have more than 72 hours if the patient didn't do it at the clinic. If the patient,
What they did with that alert.
right. If the patient completes it as soon as they get it, they have 148 hours, basically, right? So. Yes.
What are you doing for patients that are non-English speaking? So the focus is on English-speaking patients. We're remembering all these things. We're doing this, but in some Spanish-speaking, but we're missing a huge population of patients that we're not doing, which are the most vulnerable population.
Absolutely. So that's a great question. And in Miami, 60% of our patients are Hispanic, and of that 60%, over 40% are either Spanish monolingual or prefer to have a discourse in Spanish. So we have everything translated. The PRO measures, the promise cats, they've all been translated to Spanish. It's more of an implementation issue that we've been dealing with, in addition to some calibration issues with one of the cats. But we're essentially ready to go, and I've been promised that within 2 weeks or more, this pain interference CAD that's not behaving as it should in Spanish, and they're just tweaking it a bit. But yes, we're definitely rolling this out in Spanish. And the Impact program here will also do it in Spanish. An interesting challenge is we also have a very large Haitian community, and the Haitian community speaks primarily Creole, but they might not. They don't. Many of them don't read it. They cannot read it. So we're thinking of how can we work with visual, like pictographs or stories, to address these symptoms more effectively with them, because they're not going to be able to complete these PROs even if you translated them to Creole. Yeah.
Are there ways of administering questions that are audio or verbal, not with pictographs or in writing?
Not that I'm aware of, but I wouldn't be surprised if there are. I'm not aware of them, but I would think there are. Bethan, yeah. Oh, she has the pantalla charlantina, yeah. Yeah, it's so Beth Hahn actually, as Patty mentioned, had developed a while back, when I think 6-7 years ago, a kiosk that you could put at a clinic, and it's basically, I'm not sure what measure she used, but it might have been quality of life. I'm not quite sure, but she has developed something that's all visuals and pictograph driven here, yeah.
So that might be helpful.
Yeah, especially for the Creole, yeah. Yes.
With your doc goal results, how are you getting buy-in from them, or do you do post things to find out why your numbers are so low? Because I know you're seeking for 90%,
Mm-hmm.
but I don't know, do they value it? Is it a priority? Is it don't work at the time? Or
It's probably, it's many of those, actually. The biggest concern, as many of you know, it's the workload that clinicians have. And we're asking them to do more work with the promise that down the road, this should create more efficiency in your workload. It should reduce unnecessary visits, unnecessary calls, and eventually other outcomes like readmissions or ER visits. So, when you don't have something tangible to give back right away, it's a tough sell, but I think Sophia gave a really good example of how, and I'm actually going to steal that example and show it, of how the data collected guided a clinician to help the patient. So the most common response, or the most common concern or barrier we get is we're busy. It's not that they don't like it, it's not that they don't believe in it, it's that they're just too busy. So we've shifted our efforts to trying to maximize getting the patient to do this on their own, or getting to do it within the clinic waiting room on a tablet, rather than getting to the intake nurse. So that's the front end. The back end, where we're having challenges, is also with the dispositions. And in some ways, the work is duplicative, because the patient may come in, like Dr. Kircher said, if somebody's saying I have severe nausea, severe vomiting, these patients are probably so decompensated that they're aware. So the nurse, the intake nurse, nurse practitioner, or the physician seeing them may feel that this is already being addressed. Why am I going to waste my time, go in and put a disposition on something that, they just don't understand the value yet? We just started, so one of the values here is that they can see trends over time. And I think the greater value is not those severe cases, but like Sheethal mentioned, the ones that are starting to show those moderate increases over time to get them before they get to severe. That's a little bit tougher to get the buy-in from, but so it's multiple factors.
Any other questions? I'm going to ask one more.
Sure.
And I'm going to circle back to Sheethal's question about sustainability and reimbursements. And I know as a researcher, I don't know what the insurers are looking for or healthcare systems are looking for in terms of reimbursements. But it also occurs to me, are there business models where we can do an end run around the healthcare system and go straight to patients and use business models to provide services? So through, for instance, End Health.
Yeah, definitely Verizon is probably one of the cutting edge companies out of the ones that we know of, or popular ones, that has long invested into having this e-health or mHealth solutions. I know that Drippet has a new company called Health-Centric something, and it's trying to do exactly what you described. It's bypassing health systems and having like these personal health records that patients own and they can take from one system to the other, and that they're quite comprehensive. Now, how do you engage with them and how do you work with them and get the buy-in and approval from your health system at the same time? I don't know. Yeah.
Coordinate with care.
Right.
And just have it paid for
Right.
separately somehow.
Exactly.
Yeah, interesting.
Yeah.
Right. Okay. If there are no more questions, we are ready to go to lunch. Thank you all, and thank you again for your really great talk. So we are going to reconvene at 12:45 for our next speakers. Please enjoy lunch.